Welcome everybody. We're so happy to have you with us for our last session of our clinical conversations program for this year, and we are looking forward to re-upping in September. So you'll have a couple of months off from us, and look forward to being with you again in September. But we'll be communicating our topic for September in the coming weeks. So I'm Barry Sarvet. I'm the medical director for MCPAP, and our session today is on the topic of avoidant restrictive food intake disorder, otherwise known as ARFID, which is an issue that really is increasingly on people's minds today, and you'll hear lots of information about the prevalence and about some of the impact of this condition on kids in our communities. So before we get started, I'm going to give you some housekeeping information as usual, and also introduce our speakers. As usual, as you can see if you're on video, that we're offering CME through Mass General. And the code is NUPFOL, and we'll also put it in the chat in case people, because we're not going to have this slide up all the time. The session is going to be recorded as usual, and it will be available to anyone, really anyone in the country or in the world on the MCPAP website at www.mcpap.com, as will the slides be available. So you don't have to worry about taking notes. We will stop for questions as we go along, particularly if they're related to what's being discussed. Sometimes general questions come up related to the topic, but not to what's going on in the presentation. So we might save those for the end, and we'll let you know. But just enter any questions you want, and we call this clinical conversations because we want to have dialogue, with you. I want to make sure we're addressing all of your questions and needs, and really having sort of meeting in the minds about this. At the very end, we would appreciate if you could take a moment to fill out a quick sort of flash survey, so that we can get some feedback. And we're always interested in hearing about topics that you're interested in learning about, because we are in the process of putting together our plan for the next academic year, and so we're open to ideas from you. So, in terms of our speakers, we have a panel today of three really, really wonderful speakers. I'll start with Dr. Bruce Waslick, who is our own MCPAP child psychiatrist, and he is the leader of the Western Central, along with Dr. Yael DeVere, hub for the MCPAP program. He is Chief of Child Psychiatry at Bay State. He's an associate professor at UMass Chan Medical School at Bay State, and he's got all the right credentials. He's an extremely talented and accomplished child psychiatrist. Has a lot of different hats he wears at Bay State. He just finished a stint as the interim chair of the department. And fortunately, he was able to switch back to his role as the chief of child psychiatry since we completed our search. He did his training. He has medical school, undergraduate medical education at Tufts, and he did his general and child psychiatry training at Tufts as well. And he also completed a research fellowship at Columbia. He has been just a very active member of our leadership for MCPAP for the past 21 years, and we're really glad to have him. The next member of the panel is Dr. Paula Braverman, who is a pediatrician, and this is an example of our ongoing spirit of collaboration because we work very closely together between child psychiatry and pediatrics at Bay State, and they're going to talk about some of their work. But Dr. Braverman is professor of pediatrics at UMass Chan Medical School in Bay State, and she's the chief of adolescent medicine. She did her undergraduate medical education at Yale and went on to do her residency in pediatrics at Yale New Haven Hospital and also a fellowship in adolescent medicine at Cincinnati Children's. And she actually is the president-elect of the Society for Adolescent Health and Medicine. And she also represents the American Academy of Pediatrics to the Board of Representatives for the National Commission on Correctional Healthcare. And last but not least, Dr. Sarah Slabaugh, who is a child psychiatrist and assistant professor of psychiatry at UMass Chan Medical School, Bay State. She's been with us at Bay State since 2023 and is the leader of our consultation liaison service for the pediatric emergency department and the pediatric inpatient service at Bay State. She is a very, very talented clinical educator, teaching med students and residents and internists and psychiatry and child psychiatry fellows across multiple training programs. And she was awarded the Outstanding Resident Educator Award during her psychiatry residency. So she's a really skillful educator. She did her child psychiatry training at Dartmouth, where she was a clinical chief. And she did her adult psychiatry training at the John Peter Smith Hospital, where she served as the house staff president. She also completed an osteopathic internship at Suburban Community Hospital. And yeah, I think those are the key things. Oh, add to that Dr. Slabaugh is interested in the emerging field of psychedelic assisted psychotherapy in mental health, which is a very exciting area. Not as relevant currently to pediatrics, but for the field, it's a very exciting kind of avenue for growth and improvement in our work in psychiatry. And I think I will hand it off now to our speakers.
All right, so I'm here to sort of introduce what we're going to be doing today, and we're going to put the slide set up. And then I'm going to push through 2 slides, then hand it over to our 2 content presenters. We have the slide set up.
Just taking a second.
All right, there we go. All right, let's go to the next slide. So no disclosures, and we'll go to the next slide. So my job is just to set the stage. So just 2 contextual factors, which I think are important. One is that the disorder we're talking about, ARFID, we call it, Avoidant Restricted Food Intake Disorder, was added to the DSM-5 in 2013. It's existed for a long time before that, but officially recognized as a psychiatric disorder and a kind of eating disorder or feeding disorder for the first time in 2013. And we've been working with kids and adolescents with the disorder and learning more about it over the last 15 years or so. The second contextual factor is that, at least at Bay State, we're seeing a lot of kids coming to the hospital with significant malnourishment as a result of disorders of eating, whether it's classic anorexia, but we're also seeing more kids with this disorder, ARFID, who are ending up in a nutritionally depleted state and requiring medical hospitalization. So what we're going to do today is we're going to give, Dr. Slabaugh is going to give a overview of the diagnosis and clinical presentation of ARFID. Then she's going to hand off to Dr. Braverman, who's going to discuss some of the medical considerations related to evaluating and treating these kids and working with these families. We're going to circle back to Dr. Slabaugh for treatment interventions from a more sort of classic mental health perspective, in addition to all the medical monitoring and medical supplementation that folks are going to need. And then hopefully we'll have some time for questions and discussion. So next slide. So I'm very pleased to hand it over to Dr. Slabaugh to talk about the overview, diagnosis, and clinical presentation of ARFID.
Thank you, Dr. Waslick. So as Dr. Waslick shared, we've only actually had the diagnosis of ARFID for about the past 13 years. So that's actually where a lot of our, we have emerging understanding and emerging data about prevalence and incidence. But we are seeing more of this, even in the 3 years that I've been working here at Bay State, we're seeing increasing numbers of ARFID as it's complicating the presentations. And so we just wanted to kind of commonly go over things that we often hear from families, as well as clinicians, when people are coming in for the first time with an eating disorder diagnosis. Often people thinking that eating disorders are screened through growth metrics alone, or that if a child has an eating disorder, then they're going to be more sort of health obsessed or body obsessed. And that as the most common thing though is that we really often see is that we have families that there's just not been the same level of education regarding eating disorders that we have sort of in the cultural conversation with depression, anxiety, and other mental health disorders. So what we also often see is that parents can be more resistant sometimes to the history taking in this, as well as the giving of this diagnosis. So this is an area that we have seen that you kind of have to be a bit more vigilant and offer psychoeducation to families so they understand what you're asking about and what you're looking for. And we also are seeing that, and it's showing nationally that we're seeing far more diagnoses with those that are gender diverse, those that are culture diverse, and those that have other risk factors for developing mental health disorders. But we're really seeing that, eating disorders is something that is across the socioeconomic spectrum and across the lifetime spectrum as well, not just in children. And this is really just to orient you, again, to what we're seeing now. So you are likely familiar with the disorders of eating that do have body image involvement, things like anorexia nervosa, potentially bulimia. But ARFID is really in this continuum where it is restriction that is without body image. And then just to orient you here, we do see overlap between ARFID itself and anorexia nervosa. So meaning we're seeing cases where there's sensory concerns or there's other aspects where there's also body image aspects. So just to know that over the lifetime, there is going to be an interaction between both ARFID and anorexia. If you have one, you are more likely to have the other over your lifetime. It does have about a 1 to 2% prevalence over the lifetime in children and adults. So again, similar to schizophrenia disorder and other mental health disorders. So much more common than previously appreciated. And as previously mentioned, we are seeing that there is a high number of proportions in our new referrals that ARFID is ultimately their diagnosis, which is right about the national average that they're seeing. About 20% of people that are referred for care for eating disorders qualify for an ARFID diagnosis. So really quickly, just, what is ARFID? It's when we're having an eating disturbance that causes a persistent failure to meet nutrition or energy needs, plus one of the following. So weight loss, failure to gain or faltering growth, nutritional deficiencies, so that could be specific ones like vitamin D, iron, or others, or a dependence on enteral feeding or oral supplements. Oral supplements would be things like Ensure or oral supplementation drinks, again, consistently. Or the criteria of a marked interference with psychosocial functioning, not going to events, not going to restaurants, not able to participate in school, not able to participate in what we would expect culturally and with the family around food. Again, no body image component. And that with that, it is not secondary to body image. It's not secondary to food availability or culture. It is not secondary to anorexia or bulimia or another eating disorder. And it is not secondary as well to another mental health disorder. Or if there is another mental health disorder, that you're seeing a disproportionate appetite impact that you would not expect. So we do definitely see people that are, diagnosed with many things, but you're really trying to evaluate, is the appetite aspect disproportionate? So we'll talk about that a little bit in some of the cases going forward. But what we also see is that, just to note, it's that this is also developmentally inappropriate. So often you may hear families talk about, kind of developmentally appropriate picky eating. Oh, this is normal. And that there is a developmentally normal phase, and that is between the ages of 2 and 4 years old, that we do expect there to be a sort of a regression in their novelty seeking around food. But we do not expect that to persist, and we would not expect that to persist across the lifetime. And that's what makes ARFID different and unique in that aspect. And there's 3 subtypes. So that not the non-eating, there's really 3 subtypes within ARFID of the why that it's happening. So there's a fear of aversive consequences, a fear of maybe choking or vomiting or getting sick, a fear of having an allergic reaction, that they might have bloating or diarrhea. So a fear of the consequences of eating, or a normal consequence of eating. It could also be a sensory aversion. So there will be difficulties with textures, tastes, smells, appearance, needing things to be very consistent, prepared exactly the same way, or potentially prepackaged, wanting that sameness in food. Or the 3rd subtype, really, when there's a low appetite drive. So low appetite motivation, low, maybe more premature fullness, there's a lack of pleasure with eating, or more chronic insufficient intake. And we also do see in ARFID as well that it can be a combination of these subtypes. It doesn't necessarily have to be one absolute subtype, that you can see mixed reasons for the aversion, and that you can have all 3 of these, or 2 or 3 of these, or 1 of these, but it is within the 3 subtypes that it is defined. So when you are diagnosing it, you can also define more of a sensory subtype, or a fear of aversive consequences or appetite. As you can see with these 3 pathways, you can imagine that there are some differences in the comorbidities and the risk factors for them, as well as the pathophysiology. And so with that, it's kind of like, how do we get here? It seems like there's a lot of things, there's a lot of sort of syndromes that we're lumping in within this. And as Dr. Wadzik mentioned earlier, previously in an older iteration of the DSM, this was more of a non-specified eating disorder. And in this version of the DSM, they were trying to actually more clearly specify it, so that we can further understand and sort of research within the subtypes. But within ARFID itself, there is a high amount of heritability. So it's about a 79% heritability. So we think that there's a biological predisposition. Then you add in something like a food-related trauma. Maybe they had a choking event. Maybe they did eat something and they threw up or got sick, or they had something where they had an aversive consequence. And so then you have these negative feelings and predictions about eating. And again, we see this happen in many different pathways. Kids coming in through GI, maybe that had some nausea, fullness, and bloating. Kids coming in through primary care that maybe got braces, and that was their kind of aversive incident. There can be a lot of incidents that further layer in their negative feelings and predictions about the consequences of eating in day-to-day life. And then you add in things like social media and things that we're learning about in school and in our environments, where it can really start to educate them in some incorrect ways about negative feelings and fears with eating. Then as you are more restricted, we're limiting the variety and volume. When we become nutritionally compromised, we have further limited opportunities for exposure. And as you can see here, there's an interdependent relationship, which Dr. Braverman will talk about more, that we really see in the nutritional compromise and the food restriction. As they become more avoidant and the family starts to accommodate more of the limited diet, their nutrition becomes more compromised, and they become, more malnourished. As they become more malnourished, often they become more irritable, exposures become harder, the avoidance and the accommodation is often then furthered within the family. As they'll talk about in appointments, there will be dysregulation or tantrums or getting upset around food and when this is challenged. So it's a multi-layered sort of understanding, but what we do understand is that there is a high amount of accommodation within the family that further supports this, and increasing exposure, increasing awareness to the family of developmental norms is a big part of breaking this pattern. And so just some common things you may hear families talk about in the 3 different subtypes as you're exploring food with them. So in the sensory subtype, and as someone asked, yes, this more commonly happens with those that have more sensory processing differences. So that can be in autism spectrum disorder, in ADHD. They will talk about maybe eating only specific brands or certain colors, or avoiding meat because it just feels weird in their mouth, or it feels too chewy, or we only eat really hard, firm, crunchy things, or maybe food that's only prepared at a certain place at home or at school, something that they can predict. So families will often talk about these behaviors. with their kids. In the fear subtype, we'll also see a lot that within the family as well. So kids, removing certain food groups like gluten or meat or dairy that they've heard about or read about that maybe is contributing to symptoms of discomfort for them or symptoms of bloating, that they'll have identified allergies. Often that maybe are more simply what we would consider, normal process of eating, or allergies that have, again, what we would consider physiologically normal consequences. Things like, a dairy allergy that causes constipation, right? Like that's a normal physiologic consequence of eating. They may have identified bad or dangerous or fear foods. So that could be unhealthy foods. That could be just foods that make them uncomfortable. And you can hear some health related behaviors in the fear subtype as well, but it's really, again, more about the fear of eating. So they can talk about, oh, I don't think this is healthy, or, oh, I heard processed foods weren't good for me and I only want healthy foods. But really it is about getting down to the why are they not eating? Is it because they're afraid it's bad for them, or they're afraid they're going to gain weight? It's what is the fear about, that helps us elucidate these two different types. And then you will also see things like, oh, I can't, you'll hear complaints of like, oh, I can't put meds in my mouth, or I can't put food in my mouth, that they'll think that they're choke or not be able to breathe. Also, commonly, we'll hear these things in the low appetite subtypes or families. I don't eat because I feel nauseous in the morning. That's not the way, our family is. We eat one big meal of the day. Our whole family is this way. We're just kind of too busy to sit down and eat meals. Oh, we don't eat a full meal. We just snack throughout the day. We can't plan meals because we don't know what we're going to be hungry for. These are a lot of the things that we hear within families that there's some level of familial accommodation with the low appetite behaviors within the family. And then as well, as you're screening with families, they may talk about some of these safety behaviors that we often see with kids that are, again, trying to avoid in these circumstances. So cutting food into lots of small pieces, chewing it really small, drinking large amounts of liquid to try to help wash things down, maybe hiding food, throwing it away, feeding it to pets. Again, some of the things that maybe we've heard about more traditionally in anorexia or other eating disorder behaviors, but it's a different why. There's a different fear. So again, that's the starting point if we're having food related concerns, but digging into more of the fears and the why with the child is helpful. And so with these three different subtypes, there is hypothesized and understood that there's different pathways in the brain that are causing this. And so when you're in the fear subtype, that there's more negative valence within the amygdala. When you have the more sensory perception disgust subtype, that this is the insula, anterior cingulate cortex, and the somatosensory processing cortex. And then for the appetite subtype, that this is like a homeostatic appetite, lower hypothalamus drive. And they do have some literature to support that those with ARFID actually have lower levels of ghrelin and other appetite stimulating hormones, even lower than anorexia. So this is a different pathway in some ways than anorexia is. And as you can see with these three subtypes, as you can imagine, there's different psychiatric comorbidities within those subtypes. So as I think someone asked, yes, very high comorbidity with autism, some studies estimating as high as 55%. Some studies estimating as high of comorbidities with ARFID, with psychiatric diagnosis and medical diagnosis being up to 82%. We also see a really high comorbidity with post-traumatic stress disorder, anxiety disorders, ADHD, and gut-brain disorders. So we see a large number of kids coming in through GI, coming in, having presented with nausea, vomiting, these chronic feelings of abdominal pain that ultimately, they come into us, and this is ultimately an eating disorder that we're seeing. So a high amount of comorbidity that we're seeing there. And so these are just the risk factors that we know for developing ARFID. So medical and psychiatric diagnoses, just thinking about some of the medications we prescribed, how they do impact on appetite, as well as childhood trauma and neurodevelopmental disorders. There's, higher rates of disassociation in those disorders, as well as lower rates of interoception, higher rates of alexithymia. as well as those that are gender and sexually and racially diverse. Those are higher stress environments with often lower support, which can further some of the low motivation and the chronic emptiness, the chronic hunger. And then as well, we have the biological predisposition with any family history of eating disorders will predispose someone to a ARFID diagnosis as well. And so just wanting to point out, this is the comorbidity with medical diagnoses. And if you look here, I think what's interesting is if looking at section E, when we're talking about digestive conditions, as we were talking about that gut-brain interaction, from ages 7 to 11, we really see over the lifetime how much this increases. So even if you've had a digestive condition at any point, it is going to increase your risk of diagnosing of ARFID in your lifetime. So again, those differences in proprioception and interoception. And then as well, if you look at section B, so for those that have a mental condition, we really see, or a behavioral health condition as we would call it, we really see an increase from ages 7 to 11, where we see really the trajectory of that really change for kids. So that's the high, it's really seeing high risk for the patients that do have a psychiatric diagnosis, ADHD, depression, and others, really wanting to be aware of that 7 to 11 time period. And then I just noted here for the respiratory conditions, that's just from 2 to 4 that we see that trajectory change. Once we get through that, again, developmentally normal, picky eating window, it stays steady for them over the lifetime. So just to be thoughtful about medically who you're seeing and who might be at risk for it. And so just to touch on a case, very kind of common case that we see come through here. This is, a patient with ADHD who's well controlled on medication, has consistently been on the lower end of the percentile, but is creeping out of it because he's added another sport. He's not hungry. Medication supplementation has not been helpful, and then was directly admitted and found to was sent to adolescent medicine and was found to have electrolyte derangements that did require direct admission from the hospital that we were seeing that required further stabilization. But to touch on another case, which was referred to adolescent medicine, someone who more classically presents with symptoms of ARFID with the choking and aversion fears with weight loss, but was not found to be medically compromised and needing direct admission. So that takes us to our Dr. Braverman, who's going to talk a little bit more about the medical care involved with ARFID and when someone needs to be admitted to the hospital.
Okay, thank you.
Actually, I wonder, you guys should tell us if you prefer to talk about this later, but there's some interesting questions in the chat about sort of the differentiation of ARFID from kind of normal developmental pickiness and things like that, as well as some of the role of parental anxiety and parental mental health issues in terms of worrying about it and getting into sort of power struggles and different kinds of dynamics around this stuff. I don't know if that's something we should talk about at the end or if you want to address that now at all.
I'm happy. I think we might address some of these in the further slides. So I think waiting to the end would be helpful, but we can definitely address them well. Yeah.
Great. Okay.
Okay, so when I'm seeing patients, I'm looking at them from, my adolescent medicine medical point of view. And so in part, I am always looking to make sure that there isn't some other medical condition going on. We certainly have had patients with ARFID who had undiagnosed celiac disease, for example. So there always are things that are happening at the same time that are comorbid. So part of what I'm doing is looking for that. But what I'm going to focus on right now are for the kids that are coming in with ARFID. One of the main things I'm trying to do is figure out, is this kid stable enough for us to treat as an outpatient, or is this a kid who medically is not stable and should be started off on the medical floor, on the pediatric floor, to be medically stabilized before we decide what the ultimate treatment for ARFID should be. So the goals when we see patients with ARFID are to refeed them. And we have to give them enough calories, of course, to nourish them and get them back on their premorbid trajectories for their height, weight, and BMI. So we are always really focusing on the growth charts to see where was this kid tracking prior to falling off or losing weight. And as was already mentioned, it's very common for this to start at age 7, 8, 9 even. So sometimes when we're seeing teens, young 12, 13, 14-year-old teens, they have fallen off a long time ago on their growth curves, and we really have to look back even to when they were 2, 3, 4, 5 years old to try to figure out where their tracking likely should be. In the hospital, when we meet people, we can get weight gain of 1 to 2 kilograms per week, and that will normalize any cardiovascular instability that we may see in terms of postural vital signs or bradycardia. As an outpatient, in general, we're looking at 0.5 to 1 kilogram per week, or 1 to 2 pounds per week is what we'd expect in terms of weight gain. Unlike anorexia nervosa, where when we start feeding patients, we're giving them all foods, and it doesn't matter if it's their fair foods, it's something they don't like. That's part of, we just give them everything, and part of the treatment is for them to be able to eat everything and overcome that. And with food as their medicine, refeeding them feeds their brain, and helps them with overcoming those pushback issues. But in ARFID, it's very different. We actually will try to get kids and teens up to their target weight range with their preferred foods. And then the therapist will be working on exposure therapy, which we'll talk about a little bit more when I'm done, to try to overcome these psychological obstacles that are to eating. So it's a very kind of different approach. And even though we don't want to really have other kids with other eating disorders do a lot of supplementation. In fact, if they're in the hospital and they're mainly having supplements and they have anorexia nervosa, we're sending them to a higher level of care. But when it comes to patients with ARFID, we tolerate a lot more in terms of supplementation than we do with other eating disorders in terms of treatment as an outpatient. So how do we determine the treatment weight goal? So first of all, that is the weight that's necessary to get normal growth and development, go through normal pubertal development. If it's a case of a female, if they've lost their period, to have a return of menses, something, not enough food that will accommodate physical activity and sports, and also have them go through normal adolescent development with psychological and social functioning that you would for any teen going through all these psychosocial stages during adolescence. So as I said, we always consider what was the premorbid trajectory for this particular patient. One thing you want to look at is, have they begun puberty? And if they did begin puberty, what was the age of pubertal onset? So you can try to figure out, are they within that first 2 to 3 years when you expect most pubertal changes to occur? Have they not even started that process yet? And are they delayed in starting that process because they are malnourished? And that will help you kind of figure out if you still are at a place where you expect them to have a growth spurt or have some catch-up growth. And so part of what you're going to do in your physical exam is look at their sexual maturity rating. I have certainly seen patients who clearly have stopped their puberty kind of in the middle, and it's not really clear when you're looking, for example, at a female at breast development. It may look like there's really not very much breast development, but then you look at pubic hair and it's 10 or 4. So there has been some regression because of weight loss in their breast development, for example, and the child, adolescent, and the parent can tell you that. So you want to get a sense of where you are with that. A lot of people talk about the median BMI. The median BMI is a 50th percentile BMI for someone for that particular age. However, treatment goal weight is not necessarily the median BMI, and usually actually is not the median BMI. So we create a range based on the growth charts. I'm going to show you that next, how you do that. And usually we want them to be in the middle to the higher end of that range for full recovery. And in general, we need to reassess what that range is every 3 to 6 months, because either they're still growing and going through a growth spurt, and by the BMI equation, as you get taller, that target's going to keep moving up. And even people who have completed their growth spurts and really are not going to grow that much anymore, everyone should be gaining 1 or 2 pounds a year anyway. The BMI keeps going up through your at least age 20, and maybe a little bit past that because of the body composition changes, bone density, muscle mass, that kind of thing that are normally happening during adolescence. The one thing that's really hard to determine is for kids and teens who have a history of obesity. It's really less clear where to exactly put that treatment weight goal. And that is something that there's a lot of research and discussion and literature going on, but that is a little bit harder to do when you're trying to determine what that is. So what I'm showing you on this slide is on the left-hand side is a table that you can get on the CDC website. I put the website up there, and basically there's a table for males and females. 1 would be males, 2 would be females, and then you can see at the top, I don't know if you can see my pointer, but this is going to be the 5th to the 97th percentile for BMI. So basically you can calculate the age of your patient in months, and then you look over to which percentile BMI you want. You take that number, you're going to multiply that number times their height in meters squared, and that's going to give you the weight in kilograms associated with that particular BMI percentile. So here's an example of a growth chart for a patient that in general was between probably the 85th and 90th percentile for most of their life, and then dropped off right to a little bit below the 50th before they started coming back up again. So what we would be doing is looking for the BMI number associated with the 85th to 90th percentile, and we'd be creating our range based on that calculation. The other thing that we always look at is trying to classify how much malnutrition the patient has. And the reason that that's important is because if there are patients that fit into the severe malnutrition category, they are at much higher risk for refeeding syndrome, and they are someone who are much more likely to want to admit to get better monitoring of their lab work, particularly their phosphate levels. I'm going to talk about refeeding in a minute. Ideally, the best way to try to figure out their degree of malnutrition is if you have weight over the past year, you look at how much weight loss there has been over that period of time. And that will tell you whether it's mild, moderate, or severe malnutrition. If you don't have that, you can look at the Z-score associated with the BMI, and those are in the growth charts. And you can see here, there's ranges for mild, moderate, and severe. And then they also have looking at the 50th percentile BMI, the median BMI, and what percentile of that is this person's current weight. So someone who's less than 70% of the median BMI for their age would be considered severe malnutrition and at higher risk, for example, for refeeding syndrome, which might make us feel that we want to have a closer follow-up, whether refeeding, possibly as a hospitalization, where we can check them more closely. So the next few slides are actually from the position paper from Society for Health and Medicine. These are also going to be the same criteria that you're going to see if you look this up on the American Academy of Pediatrics website. And what I highlighted in yellow are the things that I thought were most relevant or most likely be seen with patients with ARFID. So having a being very low from the median BMI for age and sex, having hypothermia, bradycardia, orthostatic changes, abnormal EKG, particularly prolonged QTC, because that's a reason, a risk factor for sudden death, having electrolyte disturbances, particularly potassium, sodium, and phosphorus, having very significant dehydration, someone presenting with syncope, seizures, or cardiac failure. You can get pancreatitis potentially, and then these other complications that you can see on this slide. And then we commonly see, especially with ARFID, arrested growth and development, especially in the kids that are traditionally have very low interest in eating for long periods of time. But we also frequently admit, even if someone has stable vital signs or stable labs, if there's just a failure of outpatient therapy, we've tried, this is not working. So we want to start them on the inpatient pediatric unit to try to get them eating, to try to get their weight going the right direction, and then figure out what the next best steps will be for treatment. Also, food refusal. If there's a patient who's just absolutely refusing to eat, again, no matter what their vital signs show, that is someone that we would admit. And then any medical complications of malnutrition. So I just want to have a few slides here on refeeding syndrome, since this is a thing that's the most dangerous thing you want to avoid. Basically, you're going to get a lot of changes in terms of glycogen stores and what needs to happen for anabolic protein synthesis with refeeding, and you can get falls in phosphorus, potassium, magnesium. And these are important elements in the blood because you need phosphate to produce ATP, which runs every cell in the body. You need potassium to synthesize new cells. Magnesium is a cofactor for various enzyme systems. Also, a lot of times you can get complications of really rapid expansions of extracellular fluid volume and fluid overload. So you have to be careful when you're refeeding that you're not, they're not drinking too many fluids and become fluid overloaded during that process. So the hallmark of refeeding syndrome people think about mostly as hypophosphatemia, and among 17 studies, the average incidence was 14%. And basically, you can have multi-system failure of different organ systems without the body, which obviously is very serious and potentially could result in death. So it's a very serious complication. So this usually happens within the first 7 days of refeeding. So in the hospital, we generally check these labs every day for the first 7 days. And then the people, again, who are most likely to develop refeeding syndrome and hypophosphatemia are people who are less than 70% of the median BMI and have lost more than 20% of their body mass. So this would also include, very importantly, patients who are not underweight. So you can develop refeeding syndrome and hypophosphatemia just on the basis of losing more than 20% of your body mass, even if you are normal weight or even overweight. So that's why it's so important to look at what the different weights are and do that calculation when you're seeing patients to see if they meet those criteria. So initially, the other thing that we see is when you start refeeding, you get hypermetabolism. So your goal is outpatient, again, 1 to 2 pounds per week. In the hospital, it's a little bit higher. And for someone who does not have refeeding syndrome, for someone not refeeding syndrome, for someone who's not starting to refeed and doesn't have hypermetabolism, to gain 1 or 2 pounds a week, you need 500,000 extra calories per day. But these individuals need actually 1.5 to 2 times more than normal. So many times we have to get to 3,000 to 4,000 calories per day, and even higher in males to actually get weight gain. So to give you perspective on this, this is a graph that's showing you that you might need 80 to 100 kilocalories per kilogram per day. The average amount that a teen would need would be somewhere around 40 to 50, maybe 55 kilocalories per kilogram per day if they weren't hypermetabolic. And the thing that you can also see here is that this amount that you need stays high for a long time. So even though someone may get to the weight they need to be, it can take many months for that hypermetabolism to really slow down. So they need to also continue eating that higher level for a long period of time. So I think with that, I'm going to turn everything back to Sarah.
Great. So as Dr. Braverman mentioned, really the gold standard of treatment is nutritional rehabilitation for ARFID. So as she mentioned, when we are in that chronic state of nutritional deprivation, it is also contributing to the further food avoidance and the often irritability and further anxiety and symptoms around eating. So nutritional rehab, getting food into the child or the patient is the gold standard. Now, there's many kind of people that need to be involved to make that happen. And when you refer, we'll talk in a little bit, when you refer to adolescent medicine here at Bay State, you're working with a multidisciplinary team that includes child psychiatry, nutrition, adolescent medicine, and others. And that's going to be the gold standard of care. But when we're talking about the therapy approaches that we use with these patients, there's really two kind of pathways. So one is cognitive behavior therapy that's been adapted for ARFID. So it's really where we're using exposures and fear-based sort of hierarchies and challenging those fear-based thoughts, as well as using interoceptive exposures, meaning we're having them do things like try to get nauseous by drinking lots of water or spinning in their chair really fast to sort of evoke some of these feared feelings that can come with eating and to tolerate that as you would for an exposure, just like you would for OCD or others. Understanding what their subjective distress is, how can we tolerate that together, as well as a large part of this is around psychoeducation, normalizing and understanding, as well as normalizing the physiologic processes of the body and how to identify, what's an alarm or what's aberrant. And so then there's also literature that supports family-based treatment for ARFID. So that's more family-based treatment is more of the model that we use in anorexia, but that does have to be a family that's willing to engage in treatment and willing to limit some of their avoidance and accommodation within the family. And then as a part of that as well, we also need to have medical monitoring and psychiatric treatment of the comorbidities. For the sensory subtype, occupational therapy is often very helpful, and it's part of that exposure-based work, but it's using more sensory language than it is sort of the fear-based exposure and aversion language. So we often use the occupational therapy approach more for younger children. So again, those more in sort of the 2 to 4 range that have had an aversive consequence, those that have autism perhaps that are more limited in their ability to engage. Using that alone, that approach alone is when we would use that. There is some occupational therapy sensory features to therapies like CBT for the older age group, but it's not kind of so focused on the sensory feature as well. And so, again, nutritional therapy is the gold standard of treatment. Really, the only time we're using psychiatry and psychiatric medications is there's comorbidities that are impairing them for engaging with treatment. And so with each of these behavior therapy targets, as we talked about, family-based treatment versus cognitive behavior therapy versus occupational therapy, we're using different we're sort of using a different pathway for each. And will often be, with skilled therapists and skilled clinicians, there will often be blending kind of the modalities in some ways, and but really trying to understand what is the most predominant subtype and how do we start with that and then kind of adapt as we need to. And so really, there's two parts to it. One is about education and educating the family as to what some of these avoidance behaviors are that they may have been accommodating within the family. And then the second is to try to challenge it. But as Dr. Braverman mentioned, the goal with ARFID treatment is really nutritional rehabilitation through whatever means. So whatever if there's preferred foods, if there's supplemental nutrition, kind of whatever we need to do to get them nutritionally stabilized. And then we really introduce more of the therapy intervention where we're starting to introduce more new foods and novel foods for the patient and the family. Another big part of this is really it's about the number of exposures someone has. So an earlier question was, do you see ARFID happen more commonly in anxious families? And the literature does support that there is, like I said, it's heritable and that we do know environment contributes. There's some understanding that, child caregiver relationship does impact it, as well as parental psychopathology. But it's very similar if you think about it in a way, just like an attachment, disruption, where the parent lens of what is normal behavior, how that's getting interpreted and reflected back to the child is often where we're getting some of this, these conditioned fear responses. So yes, it can occur more often in anxious families, and when there isn't awareness of the anxiety, or there's kind of accommodation of those anxious behaviors, and that gets further solidified, is a lot of what we see in this setting as well. If pharmacotherapy is to be used, again, only we're using it to treat comorbid psychiatric disorders. So it is not uncommon that we will see patients that, pharmacotherapy has been the first line of treatment for the family. Maybe they're not able to access it. Maybe, they're really busy, but there's no literature to support it. There's no FDA approved, medications for the treatment of ARFID. Nutritional therapy is the gold standard. Where sometimes you might see medications used or someone coming out of treatment, more commonly, we're treating the comorbid anxiety disorder, panic disorder, obsessive compulsive disorder, or potentially depression or ADHD. And then often those treatment strategies look like using an SSRI for their anxiety, or an SNRI if it's more panic related, and using hydroxyzine to lower their anxiety around meals. Sometimes atypical antipsychotics will be used to try to further treat that anxiety and to stimulate appetite. But again, there's no medication that we're recommending for the treatment of ARFID. Often, pretty commonly, olanzapine will be used in the comorbidity of autism with irritability and appetite stimulation with anxiety. We've seen that be quite successful. Just to add, often people, all the data that we have on psychopharmacology is based on adult literature. None of this, with the exception of olanzapine in a very, very small study, is based on children. Ciprofloxacin and mirtazapine pretty commonly get started as part of their pathway to CS. So ciprofloxacin, often used as a adjunct for stimulant, low appetites with stimulants or other medications, but there is no literature to support that it's actually helpful. And pharmacologically, it doesn't make a lot of sense to me to be using a serotonin antagonist when often anxiety is the comorbidity that we're trying to treat with an SSRI. Just the way SSRIs, it's affecting the way the SSRI essentially can interact with the serotonin receptor. So do not recommend ciprofloxacin, and there is literature to support more and more that they're wondering if it is in some ways contraindicated, especially as we're trying to co-manage anxiety. So just please really think about that and use a lot of caution with ciprofloxacin. Mirtazapine as well, it's often used with the hope of getting them to sleep, getting to stimulate their appetite. But again, in children over adults, the pathophysiology is a bit different. And because they're also already volume depleted, they're already, low BMI often, you will see even worsened orthostatic hypotension and sort of even worsened side effects that we would see even than adults than we see when these are used. So again, just a lot of caution when using psychopharmacology, and really it's only to treat comorbidities. Psychopharmacology should not be used to treat ARFID. Nutritional therapy is the gold standard, and as mentioned, there are no FDA approved medications to treat ARFID. And as Dr. Wozlik has mentioned, it is all off-label. This is just some resources that we have put together for families. So the ARFID avoidant food restricted intake disorder, it's a really good brief guide for parents and carers if you just want to give them some psychoeducation. If you have families that are interested in doing more cognitive resources, the Picky Eaters Recovery Book actually is a really nice outline to give them as they go into treatment and therapy. Normalizing the experience for kids as well. So using, stories that they can understand their experience, and then some other resources that we've put together just in more bite-sized pieces that parents are able to understand what is normal developmental eating and how to offer exposures more easily. And that's what I have, and I'm happy to answer the further questions that we did not get into.
Thank you so much, Dr. Slaybaugh. There's some really nice questions in the chat, and I think we can spend some time talking about some of these issues. And I don't think we'll be able to get to all of them, but I think one of the questions that comes up is about the therapy. Sort of how to find, and this slide has resources, but there's I think the general question about how to select a good therapist for these patients, knowing that there are very, very few therapists who are truly specialized and resources. And so I wonder if you can speak to that in terms of, there's so much overlap with eating disorders, of like anorexia and bulimia. And so would a therapist who is qualified in treating other eating disorders be a good therapist for these patients? And maybe are there other characteristics of therapists? I guess, therapists would have to accept the patient in the first place, but if they do, what are the best kind of qualifications for a therapist for these patients, I would say?
I know I have thoughts, but I would also love if Dr. Braverman wants to answer, because I know that she interacts very frequently with therapists in the outpatient setting, and I'm sure has some very specific thoughts on what she has found to be helpful with collaboration. I know from my perspective, it's kind of two minds. One, you need someone that is really familiar with CBT and really just anxiety related behaviors in food, because often talking is an avoidance strategy, talking about it is an avoidance strategy, and there's lots of avoidance behaviors within the family and with the child that might not be recognized. So it really does take someone that is skilled in a cognitive behavior framework and also has understanding of eating disorders as well. As far as finding a therapist, there's it is challenging. It is really challenging. And I think, that's where often with our colleagues, we are trying to find out. And as Dr. Braverman mentioned, is this someone that truly needs a, intensive ARFID based therapist, or is this something where it can be more nutritional based rehab,
Yeah.
or, are there other strategies we can use? Where is that the intensity that we need right now? I think is really what
Just a quick, at Baystate, we set up a subspecialty program for folks with eating disorders. And, we can serve a lot of kids and families, but we can't serve everybody. So one of the challenges is getting these types of interventions out to the community. For integrated behavioral health specialists should learn more about eating disorders, because working collaboratively with primary care, they might be able to provide some psychological support, psychological interventions, but scaling the type of expertise that's needed to the prevalence of the disorder in our communities is a real challenge.
Yeah,
And
one of the
I
things
just
that
want to
I was just going to add that, it really matters a lot what subtype of ARFID in terms of therapist selection. And, for the ones that have more of the sensory, sort of subtype, that I found good experiences with referring some of these patients to occupational therapists, who can kind of work on, some sensory issues and exposure and things like that. And some of the kids who are more like, what is the comorbidity? If there's a experience with the comorbidity, whether it's OCD, there's a good question in the chat about the comorbidity with OCD, but, therapists who are good at treating patients with OCD sometimes can treat the fear-based subtype of ARFID, maybe with some consultation. So I think that you have to kind of look underneath the surface in terms of the diagnosis and try to find out, what some of the characteristics of the case are, and that can sort of guide you towards a good therapist. Dr. Braverman, were you going to add something?
I was just going to add that at Montanito, which is on the slide that's up, they have a specific ARFID intensive outpatient program, which is really an excellent program. It is a 3-day-a-week program. So it is also another option. The EQUIP program has limited insurances it will take. I don't think it takes any Medicaid insurances in Massachusetts, but it does take other private insurances. They also will have a component that is a totally online program. The Montanito program is either virtual or in person, although if someone doesn't go to Boston for Western Mass, it's going to be virtual. But we've had very good interactions with the Montanito Intensive Outpatient Program. They're very good at communicating and a lot of success with kids and teens who have gone to that program. So those are some other options in addition to the individual therapist or in our multidisciplinary program that we have here at Bay State.
Yeah, that was, I think thank you. And one of the questions, I wish we could get to all of them, and I think we can send them to you and see if you can send a little bit more information about some of these after the fact, if you have time. But the question about the diagnosis, in terms of differentiation from picky eaters, that we've seen, we talked even before we started, I think in the pre-discussion before we opened the session that there's this fairly intensive expansion of the prevalence of ARFID that seems to be going on that people are seeing clinically. But we're also seeing a lot of people being presented with ARFID who really have ARFID. And so just a little bit more about differentiation from picky eaters and the anxiety that parents have about feeding that can sort of lead to over-diagnosis of this condition. To say a few words about that.
Well, again, I think I'm a little bit biased because the population I see is people that have made it to the hospital. So the stories I'm hearing are the cases of families that were worried and, were kind of minimized or told, this is normal, or I think more often I'm hearing that side of things. To answer the questions specifically, yes, ARFID can be diagnosed in ages 2 to 4, but it would need to have some of that criteria that we've talked about, reliance on oral supplementation, consistent nutritional deficiency. And I think a bit of what is being asked is around that criteria of the impaired, psychosocial functioning, because that's sort of the most nebulous. And what I would be looking for is really impaired psychosocial functioning in multiple domains. So, is this, at school and at home and in other settings as well, and that we have that additional diagnostic criteria. So I think there is a lot of worry and concern about picky eating and it getting overly pathologized. And that's where I think like the Picky Eaters Handbook can be really helpful, because often what we see in families is there isn't a developmentally, there isn't a knowledge of developmentally normal limited picky eating. Your kid is going to go through this for 2 to 4 months, for 2 to 4 years. In that time period, that isn't anything to personalize, that isn't anything about, who they are or what they are, but often that does get read as preferences, and that's then really being codified into their identity. They're a picky eater, they eat very limited things. We can't offer them things or they're going to have a tantrum. And, parents just knowing that it can take 30 exposures of a new food to become even familiar with it to the point that a child wants to try it, that alone can be helpful in kind of shifting their understanding of like, oh, wow, this isn't going to be a couple of exposures and they'll eat new foods. That really is a long haul for them.
Thank you, Sarah. And as a last question, actually, even though we're over time, I hope people don't mind if just one more 2 sentences maybe about prevention, just because many of us are really in that space of really kind of doing preventive work in primary care. Any words about prevention?
Yes. Oh, thanks, Jennifer. Yes. So there is some great information actually on the family resources slide that I offered as well. Like Feeding Matters has some really helpful information for families and prevention, as well as actually that's why I added the Instagram accounts for parents, because I find that's a really digestible way for them to understand what is normal nutrition. Because I know that as pediatricians, you guys have such limited time to talk about these really normal things of prevention. And again, that's my perspective, is really talking about a developmentally normal understanding of what exposures, look like. I think I have appreciated just in the shift, since the world has become so much more online for, kids, they're at home so much more, there's less outside exposures. I'm just seeing like there's less novel exposure that kids are getting, which is increasing anxiety for them because they just haven't had that exposure. So really just talking with families about, not personalizing when things are rejected, that, rejection and playing with food and interacting with food, touching, sniffing, licking it, all of those things are steps to engagement with the food. And just helping families understand, how much novel exposure is needed for it to be incorporated into their life, I think is the biggest role of prevention that we can offer.
2 quick words. One is I think sometimes the challenging cases have to be sorted out over time. The concerns go on your radar screen as a pediatrician, and then you kind of check in with the family, the house, see how things are going. Are kids making adjustments? Are they overcoming some of their sensory challenges? And sometimes you just have to follow longitudinally to sort out whether a kid's going to kind of recover from a phase of picky eating, or they're going to move further and further into medical deterioration and concerning medical status. So some of it is you can't do it on one time. You have to sort of get an idea about things and follow things longitudinally over time.
I
Well, I
also
wish,
think that,
oh, go ahead.
I was just
Last
gonna
one.
say, I
Yeah.
also think that looking at it and then trying to intervene sooner rather than later, because when we see um kids or teenagers where this has gone on for literally years, I think it's a lot harder to change the habits and behaviors than if you had intervened sooner. So
Mhm.
it's
Early
yeah.
early identification and intervention. Well, so this is a wonderful session. So thankful, grateful for this presentation, and thank you also to the audience for all the questions. And I wish we had gotten to more of them, but we'll send any of the unaddressed questions to the speakers and see if they have a chance to give us some feedback about them. But thank you so much to everyone, and I hope everyone has a very nice summer. And we'll see you in September.